Okay, there you go. All right, so thank you everybody for showing up for another one of our international virtual grand rounds. And today I'm very excited to introduce our speaker, Dr. Namita Jayaprakash, who is all the way from the Midwest, from Michigan, that part of the United States. And a little bit about Dr. Jayaprakash. Um, So she is, unlike most of us, I think she is a board certified emergency medicine and critical care doctor. So she's one of those clever doctors rather than just a plumber like we are. Uh, and she has a particular interest in sepsis and early intervention in sepsis and other critical illnesses. Um, uh, she graduated from the University College of Dublin in the Republic of Ireland, and then she did basic specialist training in the Republic of Ireland. I hope she developed a nice interest and taste of Guinness while she was there. Um,
Indeed.
and then she gained membership to the Royal College of Emergency Medicine in the United Kingdom and in Ireland. And then she moved to the United States. She did a residency at Henry Ford Hospital in Detroit, and then a critical care fellowship at some unknown place called the Mayo Clinic in Rochester. Currently, she is the Associate Medical Director for Quality for the Department of Emergency Medicine at Henry Ford Hospital. And she is the lead physician for the Henry Ford Health System in the management of sepsis. And from an academic perspective, she is a clinical assistant professor in emergency medicine at Michigan State University and Wayne State University, both in Michigan. And today, we're going to hear her presentation of the biology behind the sepsis bundle, the art of smarter sepsis treatment. So, without more of ado, I'm going to hand over to Dr. Namita Jayaprakash. Thank you very much.
Oh, thank you. Thank you so much for that kind and warm welcome. Good afternoon to you all. Here in Detroit, we're just day is just ri starting. The sun's just rising. It's still a little bit dark outside. It's the peak of winter. And it is a great honor for me to come talk to you. Thank you so much for this invite. As you heard a little bit about me, I am an EM critical care physician, and I do have a passion for sepsis. It is the disease that sort of spans both of my specialties, but more importantly, leading the health system sepsis program, it's one that we've been able to make a huge impact. And over the last 5 years at Henry Ford Health, focusing on early interventions and delivery of sepsis care with the bundles, we have been able to save 312 lives at our health system alone. So I'm really excited to share a little bit about sepsis and the connection between the pathobiology and the how we manage sepsis. I am a researcher as well, so I do serve as the site PI for an NIH funded study right now, the AIM study, assessing the implementation methods in sepsis. And I'm a voluntary medical advisory board member for Sepsis Alliance alongside my duties at Henry Ford Health. Our roadmap today is going to start off by defining sepsis. I will talk a little bit about the pathobiology and physiology of sepsis. We'll touch on how to identify and manage sepsis, and then we'll wrap things up with the impact of sepsis bundles. Sepsis is a life-threatening organ dysfunction caused by a dysregulated host response to infection. So why does it matter? In 2017, the World Health Organization conducted a global study of sepsis and identified that there were 48.9 million cases of sepsis globally. 11 million sepsis related deaths, and 20% of all global deaths were being attributed to sepsis. So that's an incidence of 189 per 100,000 person years across our globe, with a mortality rate of 26.7%, rising sharply to 42% if you have ICU treated sepsis. Sepsis survivors continue to have impacts on their life. 1 in 3 sepsis survivors might die within the next year after their index hospitalization. 1 in 6 survivors experience significant long-term morbidity, and 40% will be readmitted within 90 days of their index hospitalization. The impacts of sepsis on survivors can range from chronic lung disease as the sequelae of their ARDS, neuromuscular disorders, chronic heart failure. Lives can look very different after a hospitalization with sepsis, emerging with the need for dialysis and taking trips to dialysis centers 3 times a week. There are increasingly reported findings of mental health impacts and psychiatric disease after ICU stays, and in particular after sepsis. And then, in the worst cases of patients who have septic shock, they may even end up with disabilities from amputations as a consequence. So, how do we define sepsis, or how have we gotten to that definition of sepsis? The first references of sepsis go back to Homer's poems in ancient Greece. And it's, in fact, a term derived from ancient Greece that was meant to define the decomposition of animal and vegetable organic matter. Hippocrates viewed sepsis as a dangerous biological decay, and Galen believed that sepsis came from these invisible creatures giving off fumes and known as miasma. As we moved into the 1800s, though, the shift in the paradigm of our understanding of sepsis started to change. And there was more of a understanding that it wasn't internal decay, it was in fact the result of harmful microorganisms. Semmelweis sparked great controversy when he linked puerperal sepsis with contamination. But implementation of hand washing for doctors reduced the incidence of sepsis, really making that connection again of the harmful microorganisms. There was great strides made with Louis Pasteur and Robert Koch, who transformed our understanding of wound sepsis, recognizing that pathogens could enter the body through breaks in the skin. As we moved into the 1900s, Edward Frank in 1964 published a protocol of management of of septic shock, really highlighting and advocating for the need of the presence of the bedside physician. I'm focusing on hemodynamic monitoring, focusing on resuscitation to restore cardiac and respiratory support, the correction of hypovolemia, mechanical vent support, inotropic support. And I did really emphasizing the identification and prompt treatment of causative infections. In 1976, R.F. Wilson said, any trend which suggests increasing sepsis should be treated aggressively, especially if shock is present. He emphasized that earlier the therapy is begun, the better the results, and highlighted that some of the greatest errors in therapy of severe sepsis and septic shock are delayed control of the primary septic process, giving too little fluid in the early phases of therapy and too much later, and delaying ventilator assistance if the patient's ventilation of blood gases are deteriorating. But despite all of this recognition and understanding of the severity of this illness, we in fact didn't really have an operational definition of sepsis until 1992 that could be applied at the bedside. In 1992, the American College of Chest Physicians and the Society of Critical Care Medicine came together at a consensus conference to really put pen to paper and define this syndrome that was recognized as carrying a high mortality risk. And it was there that Roger Bone advocated that the systemic inflammatory response syndrome was our first recognition of the host response to infection. And so was born that first definition of sepsis being an infection or a suspected infection in the setting of 2 or more SIRS criteria. And the descriptions of the continuum, the sepsis, severe sepsis, septic shock to multi-organ failure. This was really transformed the ability to recognize sepsis early at the bedside. In 2001, the American College of Chest Physicians, the Society of Critical Care Medicine, came together with their European counterparts and revisited to really ask the question, do we need to revise the definitions? And they concluded that maybe we don't need to refine the definitions or revise them, but we do need to have a more of an expanded list of diagnostic criteria. And so in 2001, the Sepsis 2 definitions focused on identifying organ dysfunction criteria. For many years, we continued to use these operational definitions of sepsis until 2016, where it was time to revisit and ask that question again. Do we need to revise the definitions? And so in 2016, a joint task force published the definition that sepsis is a life-threatening organ dysfunction caused by a dysregulated host to infection. Now, this task force did recommend that we move away from using systemic inflammatory response syndrome and using severity of organ failure assessments or SOFA scores, as it has greater predictive value for predicting mortality in relation to ICU related sepsis. Now, this was still controversial because for 20, 30 years, the operational definition seemed to have great sensitivity for picking up those early cases. And so in reality, we currently live in a world where we have a bedside operational definition that's often used of the sepsis 2 criteria and then the sepsis 3 criteria, which identifies the risk of progression of illness and mortality. But I will tell you that I think for me, thinking about sepsis as a condition, you've got to think about it as this life-threatening organ dysfunction caused by a dysregulated host response to infection. Though I can't really explain that to a patient, and I can't really tell a junior physician that go to the bedside and pick up the dysregulated host response. So pragmatically, having the systemic inflammatory response syndrome criteria and in my brain helps me identify patients at risk for sepsis. So let me move into the pathobiology and physiology of sepsis. If we go back to that dysregulated host response of infection, that's truly what's happening. There is an infectious insult, and the infectious insult might be bacterial, viral, fungal. The highest incidence of sepsis continues to remain gram-positive and gram-negative bacteria. Though in the United States, Candida infections and fungal infections are the number 3 cause of sepsis. There is an international study that looked at pediatric ICU populations and identified that 21% of PICU sepsis was in fact viral. So the pathogen can vary, but the infectious insult, it results in this upregulation of pro and anti-inflammatory pathways that results in system-wide release of cytokines, of mediators, of pathogen-related molecules, causing phagocytic dysfunction, lymphocytic dysfunction, endothelial dysfunction, coagulation disorders, and ongoing release of these mediators that ultimately take the pathway of infection leading to organ injury. And that's what defines sepsis, is the organ injury. It's that syndrome. The hallmark is most definitely the immune response. And what's interesting is that this inflammatory response that the pathogens induce can be both pro and anti-inflammatory. And the reason sepsis is such a heterogeneous disease is that it's really hard to predict the host's balance of pro and anti-inflammatory responses. In the early phases, you have the innate immunity, and then the adaptive immune system kicks in. Though the anti-inflammatory events over time do contribute to immunoparalysis. And that immunoparalysis is key because that's what puts patients at ongoing risk for nosocomial infections, for viral reactivations, for endotoxin release, and that pathway of recovery versus deterioration. So while the immune response is active and you've got this balance, that immunoparalysis aspect is also driven by the infection, leading to quantitative and qualitative alterations in antigen presentations, the B cells, T cells, activation of or depression of low immunoglobulins, defects in neutrophils. There is the pro-inflammatory hypercytokinemia with the release of IL-6, IL-8, TNF-alpha, etc., defective bacterial killing. And so all of this continues to be driven when there's poor control of the infection. And that immunopathology places a patient at risk for things like viral reactivation, etc. So this complex syndrome leads to that influences progression is the interplay of pathogen modifying factors, and that could be related to the load, the virulence, the immunogenicity, the microbiome in the host, the nutrient availability. Bring that together with host modifying factors such as age, immune status, coexisting conditions, barrier integrity, environment, the genetic factors. And then the balance of that impaired immunity with excessive inflammation. And the end result is a combination of microvascular injuries and the common organ failures that are diffuse, can affect the brain, delirium, encephalopathy, The lungs, ARDS, respiratory failure. Kidneys, acute kidney injury, very common. Shock, cardiomyopathy, acute liver injury, and coagulation disorders, the worst of which is disseminated intravascular coagulation. So, understanding the pathobiology and that interplay of pro and anti-inflammatory host response, as I describe the clinical phenotypes, hopefully it'll start to make sense of why it's such a heterogeneous disease. There's been a lot of work and efforts to describe the biological phenotypes, and a ton of work in transcriptomics, immunophenotyping, and protein biomarkers. Some of the pro-inflammatory biomarkers that have been utilized include CRP and procalcitonin. None of these, however, have really borne out to be the gold standard for diagnostics. So they are biomarkers. They give us a sense of what might be happening, but they most definitely are not necessarily diagnostic. In the immunosuppressive phase, there's been some work on HLA-DR, and then organ dysfunction. So lactate, the differences in venous and arterial carbon dioxide pressure. Another one, a hormone that has been a bit of work done on is adrenomegaline. The coagulation phenotypes that are emerging. So in this secondary analysis of two large multi-center sepsis registries in Japan, there's an emerging pattern of different phenotypes and described as clusters DA, DB, DC, and DD. And the variation of their coagulation profiles are correlating with different mortality profiles. So cluster DA has a severe physiological status and organ dysfunction, coagulopathy, high lactate levels, and it carries with it a high mortality, with 90% requiring vasopressors, compared to cluster DD, which is a much milder form of disease. Chris Seymour and his group have done some great work in deriving and validating potential phenotypes that might have treatment implications. And so in their study, what they did was identified four phenotypes, alpha, beta, gamma, and delta, that have very different profiles. So, for example, the alpha, few abnormal lab values, less organ dysfunction compared to greater chronic illness, more likely to have elevations in inflammatory markers or elevated serum lactate levels and hypotension. And what's interesting is that these distinct phenotypes have patterns where the mortality, in-hospital mortality in particular, is very different, with the highest mortality rates in that the cluster which has the elevated lactate levels and hypotension. So there's a lot of work, like I said, and where does the future in phenotyping? There's opportunities to have large prospective and retrospective cohorts that we can take those and look at their structural clinical data, their lab data, proteomics, transcriptomics, immunophenotyping, metabolics, metabolomics, lipidomics, and think about, can we use new technology and machine learning to do some phenotype modeling, and perhaps subphenotypes will start to emerge. And then the real question is, can we use these for identifying treatable traits? But for now, when we think about the pathobiology of sepsis, the clinical features can really be largely distributed into hemodynamic alterations and metabolic alterations. And to understand the hemodynamic alterations and metabolic alterations, I think we have to go back to some basic physiology. And an essential lesson to understand when treating and managing patients with sepsis is the physiology of oxygen transport, defining tissue hypoperfusion. Global tissue hypoxia, that's a measure of shock. So what's really happening? We have an oxygen balance, and the balance is a relationship, a very close relationship between demand and delivery. And anytime the balance is off, for example, as delivery goes down or demand increases, what's happening is this global tissue hypoxia. When global tissue hypoxia occurs, the cells are switching from aerobic, anaerobic metabolism, and there's a release of lactic acid. And we use the marker of lactate greater than 4 or lactic acid greater than 4 as a measure of global tissue hypoxia and shock states. Well, why? The seminal lactate studies were conducted by Max Harry-Weil, who is a grandfather of ICU care, one of the originators of the Society of Critical Care Medicine, and highly respected researcher. What his group studied was that excess lactate was indeed an indicator of oxygen debt. It's a metabolic index of severity of the shock state. And what they found was that a level greater than 4 was associated with a sharp decrease in the probability of survival. So you can see in this shape, sort of a reverse S-shaped curve, at that level of lactate greater than 4, the probability of survival starts to go down significantly. And that's where lactate greater than 4 as a marker of metabolic stress of associated with mortality and why it should be a definer for shock states started to emerge. And this carries through. In 2014, when the ARISE investigators published the goal-directed resuscitation for patients with early septic shock, they also conducted an a priori analysis of a subgroup in which there was high lactate levels, compared them to just isolated hypotension. And the patients with isolated hyperlactatemia, well, they had higher 90-day mortality. They were less likely to be discharged from alive from both the ICU and the hospital. They had longer ICU and hospital admission. They ended up being ventilated more frequently, and they required vasopressors for longer. So that lactate level greater than 4 continues to really define a worrisome state and a definer for metabolic shock states. Moving on to sort of a macrovascular, like the physiology of oxygen transport in true, how do we get the oxygen around? We have to go back to our understanding of the cardiovascular system. And the relationship between cardiac output and the content of oxygen is really important. So the content of oxygen is influenced by your hemoglobin times the saturation, and there's a small amount from the dissolved amount of oxygen in the blood. So the real players in the content of oxygen are actually the hemoglobin and the saturation. Now, cardiac output influences our ability to get this oxygenated blood around to our different organs. So if we take a cardiac output of 5 liters per minute, oxygen delivery can be calculated at about 1,000 mils per minute. Once our tissues are extracting the oxygen in homeostasis, in normal states, they are returning about 75%. So after consumption of around 250 mils or 25%, about 75% is returning to the right side of the heart. And that's where we target our venous saturation levels when measured through a Swan-Ganz catheter at SpO2 ranging from 65 to 75%. So Conrad Reinhardt in 2004 with his group really mapped out the correlation between a central venous oxygen saturation versus the venous oxygen saturation. So a central venous oxygen saturation is measured through a standard triple lumen catheter at the confluence of the SVC and the right atrium, compared to an SVO2 that requires a pulmonary artery catheter or Swan-Ganz catheter. And he mapped out a consistent pattern where there's about a difference of 5% or so. So when we talk about SCVO2, we talk about a target of 70 to 75%. So if you have a low oxygen saturation, then you got to be worried that there is actually a delivery problem because perhaps oxygenated blood is not getting around to the cells. So is that because there's a low saturations or low oxygen content? Is it because there's a low hemoglobin? Or is it because the cardiac output is down? If we go back to that balancing scale, so oxygen, the delivery and the demand have a close relationship. So if it's not a question of delivery, could it be that the demand is up? So conditions that induce stress, pain, hyperthermia, shivering, work of breathing, these are all things that will increase the oxygen extraction, resulting in decreased saturations going back. So the sweet spot is the 70 to 75%. We're all good, perfect. That's our target. But what if it's high? Well, high saturation levels are also worrisome because that could be a signal that the mitochondria are dysfunctional at a cellular level. And in fact, the oxygen that is being delivered is not being extracted. So it's a really good marker of what's happening at a metabolic level. Is there metabolic stress? So high oxygen saturations are bad. does this pan out in real life, this theory? Absolutely. So Gattinoni and et al. In 2019 plotted some interesting correlations. So they took sextiles of SCVO2 and compared them to lactate levels. And if you know, both low and high SCVO2s were associated with elevated lactate levels. Similarly, there was an association with SOFA scores and again with mortality. So that sweet spot is indeed about 70 to 75%. So the continuum of sepsis is really this balancing act. And a lot of times, what we see at the bedside is hypotension. And that hypotension is really a representation of what's happening because you've got the infectious insults, you've got these soluble mediators, that the pro and inflammatory cascade, and in the hemodynamics, the end result is increased capillary permeability and it's a decreased vascular tone. That combination presents itself as hypotension at the bedside. If we go back to that delivery of oxygen, we talked a lot about the oxygen content, but I want to remind you that the second piece of delivery of oxygen is cardiac output, and cardiac output is influenced by heart rate times the stroke volume. And it is a stroke volume that can be further categorized into the preload, what's happening at the afterload part of it, and contractility. So in preload, as the capillaries are getting permeable, the endothelium is injured, we have this effective absolute or relative hypovolemia that's happening in sepsis. And that's where the importance of the fluid challenge comes in. The fluid challenge is really designed to reestablish preload as much as possible. The afterload, the decreased vasomotor tone, the answer to that is vasoactives. Contractility supporting the inotrope. So in the sequence of sepsis management, we are targeting preload, then afterload, and contractility. So let me move into management of sepsis to try and bring it all together. The pillars of management of sepsis remain early identification, risk stratification. So we measure the lactate to get a sense of how sick is your patient, is incredibly important to evaluate for sources. Deliver antimicrobials, intervene for sepsis-induced hypoperfusion, and reassess the patient. Let's start with the identification piece. I mentioned to you at the very beginning the definitions of sepsis. We live in this world where we value the importance of that host response. And how do we understand what's happening with the host response? So there are many different criteria that are suggested for recognition of sepsis, including the traditional SIRS criteria. There's SOFA scores and Q-SOFA scores. What we do know is that the time to sepsis definition is significantly shorter using SIRS, because SIRS identifies possible sepsis 118 minutes before SOFA scores in emergency department populations. And the nature of SIRS is that it is highly sensitive, but it's not as specific. SOFA, higher specificity, so great correlation with predicting mortality. Currently, in the most recent published surviving sepsis guidelines, they do recommend against using Q-SOFA, which is the quick SOFA, compared with SIRS, NEWS, or MUSE as a single screening tool for sepsis or septic shock. The history and physical examination in sepsis is also a very important factor in that identification and risk stratification piece. Capillary refill time is a great marker to get a sense of what's happening with the organ dysfunctions, in particular the skin, because our physiology is such that our bodies divert blood flow to improve critical blood flow to organs such as the heart and the kidneys. And the first space they divert it from is our skin. So the modeling score has been proven to predict survival in septic shock. And the greater the degree of modeling, the greater the association with higher mortality. Survival is lowest in the 4 to 5 range, with scores of 0 to 1 having much better improved survival with time in ICU. So if you needed a physical exam perfusion assessment checklist for patients with sepsis, think about looking at their vital signs to pick up on their heart rate, their respiratory rate, even their blood pressure. Think about the cardiopulmonary exam, add in your capillary refill, check the peripheral pulses, and don't forget the overall skin examination. Moving on to the next important essential pillar, the treating the source. As I mentioned to you, the most common pathogens that induce sepsis remain gram-negative and gram-positive bacteria. And so time to antimicrobials is an important correlation. So the reason when you're suspecting a patient with sepsis, you often don't know what the source is. So we go with our best guess, and therefore antibiotics are a very reasonable first line. For every hour delay in antimicrobials, the probability of mortality increases, such that if antimicrobials are delivered within that 0 to 1 hour compared to greater than 6 hours, there's an 8.5% increase in the probability of mortality. So the timeliness of the delivery of antimicrobials is essential. And the Surviving Sepsis Campaign's 2021 guidelines suggest a paradigm in which when we think sepsis is definite or probable, administer those antimicrobials immediately, ideally within an hour of recognition. But understanding that there are diagnostic dilemmas, especially for somebody like me as an emergency physician, when a patient comes in, it's not necessarily that they have their diagnostic label tattooed on their forehead. There are some times where you need a little bit of time. If shock is present, don't wait. Administer antimicrobials. If shock is absent, we have an opportunity to do a rapid assessment, but it's not an unlimited. It really still is administer those antimicrobials within 3 hours when infection is being considered. So the goal of early management of sepsis, because as I mentioned, a lot of times I don't know what my patient's sources are, especially blood cultures, even though PCR technologies have improved the time to identification of microbes, it's still not rapid. It's not within an hour. And so a lot of times I do have to initiate selecting those antimicrobials based on national guidelines, local susceptibilities, patient's factors, and then thinking about what are the most common pathogens for the suspected source. But as an intensivist, I have the opportunity then to evaluate daily. I can review the progression and improvement. I can look at and understand what cultures results are available. What are the molecular diagnostics? I can analyze the dosing strategies, and then I aim to de-escalate as soon as possible. And so narrowing therapy based on cultures to minimize those adverse effects. So initiate, evaluate, de-escalate. And so most relevant to all of you from a surgical perspective is source control. So there's antimicrobials, but there are many sources. In fact, antimicrobials alone may not help. So source control in the management of severe sepsis and septic shock is essential. And thinking about drainage for abscesses, debridement, device removals, definitive measures are absolutely essential as a partner for those early antimicrobials. Every hour of delay from admission to surgery is associated with an adjusted 2.4% decreased probability of survival compared to that previous hour. So that timeliness factor is absolutely essential. Moving into goal-directed resuscitation, bringing us back to this balancing scale that our physiology, our bodies do, oxygen demand and delivery lives in this finite balance. And oxygen extraction is really influenced by conditions such as sepsis that might, if you recall, affect the cellular functions. And so in resuscitation science for sepsis, the goal is to take this unhappy cell in shock and convert it to the happy cell. And the steps to do that are very much rooted in our understanding of physiology. So there's the risk stratification to get a sense of what's happening at a cellular level. And the thing that is a quick test, very accessible for somebody like me, where the use of the bedside lactate test has significantly increased over the last 2 decades at my institution. But a lactate is a quick test to tell me what's going on with the patient. A lactate greater than 4, the timeliness of my treatment and the prioritization of this patient is very different from a lactate that's normal. When we think about that oxygen, but restoring the demand and supply equation, I have to think about delivery of oxygen, the content of oxygen, the cardiac output. I have to think about balancing out, is there pain that needs to be treated, hyperthermia, shivering? Is there work of breathing that should be addressed to reduce the consumption of oxygen? So the resuscitation targets are very goal directed, rooted in physiology. Restoring the microcirculation and assessing the interventions, the endpoints of resuscitation. How is the lactate doing? What is the SCVO2? What are the physical exam findings? Am I making progress in my resuscitation? I don't know about your practices, but I will tell you that in the United States, we have entered this phase of hydrophobia. It feels like there is a worry, there's a resistance to providing fluids in patients with in sepsis and sepsis-induced hypoperfusion in particular. And so I often ask my residents, "Are you hydrophobic or hydrophiliac?" But really, the target volume for resuscitation is not too much, not too little, and it is 30 mLs per kilo. Even in patients who have conditions that might make us worried about fluid management, such as heart failure, end-stage renal disease, and cirrhosis. In this study, there was a comparison between a restricted patients who got less than 30 mils per kilo versus a standardized group greater than 30 mils per kilo. And there's no difference in the rates of intubation, the time to intubation, the mortality of ventilator days. In fact, there could be harm in patients with congestive heart failure. The hazard ratio starts to increase with lower amounts of fluid. And those who get a bundle compliant amount of fluid had higher survival probability compared to those who didn't. The type of fluid, very clearly, what's emerging in the literature seems to be balanced crystalloids is favored over saline. For sepsis patients in particular, the improvement it very much seems to favor balanced crystalloids. Albumin as a resuscitation fluid has a signal. And in the SAFE study, the signal, it was the first time that there was a clear signal for the severe sepsis population. What is less clear, though, is the impact on mortality. There does seem to be a signal of benefit, especially for septic shock, but not as clear of a benefit yet. And so currently, the 2021 Surviving Sepsis campaign, they do recommend crystalloids as the first fluid of resuscitation. In 2021, they suggested balanced crystalloids, and we're waiting for their updated recommendations this year. The fluids were addressing the preload component, the venous aspect of it, because you've got this effective hypovolemia that can happen in sepsis. But then there's also a decreased systemic vascular resistance because of these soluble mediators that are decreasing the tone, and that's where vasopressors are essential. The target blood pressure remains 60 mean arterial pressure of 65. And there have been studies that have compared high versus low blood pressure targets in patients with septic shock. And really, the cumulative survival, there was really no statistically significant difference. So targeting MAP of 65 continues to remain the recommendation for patients with sepsis. We have a vast array of vasopressors in which we can choose, depending on whether is your patient hypotensive or tachycardic. Perhaps we might be considering things like phenylephrine or epinephrine or norepinephrine. But maybe for the patients who are hypotensive and bradycardic, you're not necessarily seeking that alpha adrenergic response and might gravitate towards dopamine. Well, I will tell you that the studies in patients with septic shock have really borne out that norepinephrine remains first-line choice, especially compared to dopamine, with a lower risk of mortality and a lower risk of arrhythmia. So norepinephrine is the safer and best first-line agent for patients who continue to have hypotension despite early volume resuscitation. There is some signals that vasopressin in septic shock has a benefit, not so much the mortality benefit as much, but it does seem to be effective in reducing the amount of vasoactive medications. And so it's recommended as a second line agent. I will briefly touch on information around angiotensin II. Well, the trials have shown us is that the bottom line is the patients who received angiotensin II, they have better mean arterial pressures at hour 3 and lower requirements of catecholamines and lower cardiovascular scores. The impact on mortality is not as significant. And so, as institutions are deciding, do they want to adopt angiotensin as an additional vasoactive agent? Sometimes the balancing act is the cost benefit ratio in that. Steroids they have a long history, over 50 years of getting an understanding of steroids and their role in septic shock. And most recent trial was adrenal and practice trial. And where we really do see a benefit of the addition of steroids for patients who have ongoing requirements of vasopressors. And the dosing is in the hydrocortisone 200 milligrams per day, given in split doses of 50 milligrams every 6 hours, or as a continuous infusion if that is accessible, with the addition of fludrocortisone. And the suggestion that Surviving Sepsis Campaign makes is that consider this addition of steroids after at least 4 hours at which your norepinephrine doses are greater than 0.25 micrograms per kilogram per minute. So now that we've gone over the key pillars of management, let me briefly describe what delivering that sepsis bundle, which really is all encompassing of those pillars that we just talked about. What is the impact at the bedside? So in the beginning of this talk, I was introduced as being from Detroit, Michigan, and Henry Ford Hospital has a very long, impactful history with management of septic shock. I'm very privileged and honored to work in the department and be mentored by Manny Rivers, who published the early goal-directed therapy and treatment of severe sepsis and septic shock in 2001. This was a single center emergency department based trial. The ICU was blinded, and the guiding principles of the trial are early identification of high-risk patients and early hemodynamic optimization of oxygen delivery. So going back to the pathobiology and the physiology and science of resuscitation, these were the real guiding principles of early goal-directed therapy. And it really is a verb and it's not a noun, as Dr. Rivers will always tell me. And the focus is including trying to do early fluids when appropriate, adding vasopressors, thinking about do inotropes need to be added? What is the lactate? What's the clearance? Hematocrit goals for delivery oxygen and SVO2. But why this trial is a landmark trial is it absolutely changed the approach to sepsis management internationally. It was after the publication of the early goal-directed therapy trial that the Surviving Sepsis Campaign published its first guidelines in 2003. And the United States landscape of guidelines, protocols, and policies have really evolved over the last 25 years since its publication. So pre-EGDT, the septic shock mortality was in the range of 51%. For the trial, the control was 46%, with the intervention arm mortality of 30%. And in 2021, management of septic shock carries with it a 20 to 25% mortality. So since the publication of the trial, we've seen huge improvements in how we approach sepsis, really that concept of early identification, hemodynamic management, and the impact is significant. So the approach that the Surviving Sepsis Campaign recommends is timeliness is so essential. So when you recognize patients who have sepsis, think about delivering this bundle of care where you're measuring lactate, obtaining blood cultures, administering broad spectrum antibiotics and fluids for those who have signs of hypoperfusion, and applying vasopressors, and do it as soon as you can. The next update of the guidelines are expected to be announced in March 2026 at the Society of Critical Care Medicine. So I'm really excited to see what changes they will be recommending. In the United States, there's a Center of Medicare and Medicaid Services, and they recommend the SEP1 bundle, which is really a process bundle for patients where the idea is to recognize the change in patients early, suspect it, identify or consider the infection as the driver, determine if there's an end organ failure present, make the diagnosis of severe sepsis or septic shock, and then deliver the treatments. And they give a 3 and 6 hour window. The 3 hour bundle still is risk stratify the patient, initial lactate, obtain the blood cultures to identify the sources because there's still a high level of bacteremia as a source of sepsis, administer broad spectrum antibiotics, and deliver fluids for those who have signs of hypoperfusion. Within the next 3 hours or within 6 hours, make sure that we're reassessing the patient, repeat the lactate, check 2 blood pressures, see if the hypotension is resolved. And if it hasn't, add the vasopressors and then prove that you've done the reassessment and complete the reassessment. Does the SEP1 bundle make an impact? Well, in the United States, Dr. Townsend and colleagues did an analysis of patients who received the bundle versus not, and they did a standard match and as well as a stringent match, and found that there, in fact, is a improved mortality for patients who received the bundle. So that's the SEP1 cases. Well, in New York State, there was an interesting approach. It was really on the landscape of regulations and in which the sepsis bundles were emphasized. And so in 2013, there were Rory's laws that introduced the importance of delivering a sepsis bundle early. After the introduction of the New York State bundle, there was questions of, well, are we just getting better at management of sepsis? Is it really the bundle? Well, it turns out that when you compared the improvements in New York State compared to control states, after the introduction of the New York State Sepsis Initiative, there was a significant relative decrease seen in the adjusted risk of 30-day in-hospital mortality relative to control states. So more evidence to support that this bundled approach that incorporates understanding the host response to infection, controlling the source, may in fact be saving lives. So the key takeaways I have for you is that sepsis is a dysregulated host response to infection. The pathobiology is influenced by the interplay of the pathogen, the host, and the balance of these pro and anti-inflammatory responses, resulting in this heterogeneous disease. And while we understand the pathobiology much better than we did during ancient Greek or Roman times, or even the 1800s and 1900s, the nature of the disease is such that the most effective management lies in targeting the features of sepsis, of improving the hemodynamics and the metabolic responses and controlling the source. So the sepsis bundle, which are really rooted in that balancing act of control the source, address the hemodynamic perturbations. If you deliver it early, that early recognition and early intervention, that's what makes a difference in patients' lives. So risk stratify, lactate's a great tool to do that. Obtain the cultures, treat with broad spectrum antimicrobials, recognize the hemodynamic and metabolic alterations, act quickly to resuscitate and stabilize the patient, and you will save lives. Thank you so much. I will leave you with this. Sepsis is a collaborative sport. Nobody can do this alone. So please reach out to colleagues across the aisle because it very much is an all-in, all hands on deck. Thank you so much. I'm happy to take any questions.
Great. Fantastic. I don't recognize Detroit.
Yeah, most people can't believe, but this is our Detroit riverfront.
Wow, it's amazing. Great talk. I'm going to open up the floor to any questions or any comments. Ellie, of course.
Yeah, thank you very much. It's a great talk, and it's your talk related directly to our daily practice because sepsis is one of our main enemy in surgery. In terms of treatment of sepsis, I think today's guidelines pretty clear. I would like to ask you, what is the new in terms of prevention of sepsis? What do you have any tips, daily tips for surgeons? What we have to do to wash our hands? We are washing hand since 200 years. Prophylactic antibiotics we are using regularly. We know that we have to do surgical interventions on times in order to treat surgical disease. What else? What is the new? I mean, what you can suggest to surgeons to do?
Yeah, no, that's a great question, and that's the interplay between the pathogen and the host is really where it gets complicated, and being able to predict who is going to get sepsis versus not. There is a lot of work that is being done that's fascinating to me on understanding the relationship of the gut microbiome as a host risk factor. And so I think this is an emerging space that might give us some good insight into some preventative strategies, perhaps in modifying the host response. So that is like a space to watch, is that the emerging evidence on the gut microbiome and the influences of the gut microbiome. I think there's two groups of patients. There's the elective, you have the ability to plan and optimize the host. But then they've got the emergent group where something has catastrophically happened. And so both groups are really interesting. And the why the sepsis remains this very complicated heterogeneous disease is because there's also a lot of data to say you can treat, for example, a staph infection. You can treat a patient with for antibiotics, they improve, they get home. Well, why did they get readmitted? A third of those cases are because the organism mutated. And it's a different form of staph. And so the ability for us to identify which of those, it still feels like a black box. But for me, I think there's the emerging understanding of the gut microbiome and the relationship will help us with optimizing the host. The other area that's really intriguing is some of these new devices that are not only they're able to give us signals on is it bacterial versus viral? But what really intrigues me are the ones that actually do have a illness severity score associated with it. And so it's the interplay of host response as well as what is the pathogen. And right now, they're really being marketed towards first arrival emergency department patients, but I think there really needs to be more understanding in the hospitalized patient and the utilization of those types of tools in the hospitalized patients to help predict or at least get a sense of who is at risk. And that's research that really hasn't been done. The money is more in the where is the common, the more common prevalence of the illness. There's still 75 to 80% of community acquired sepsis presenting to emergency departments. So often when I'm like, can we do some research in the hospitalized patients? Their companies are not quite so willing to do that. But that's another intriguing area that might help pick out which is that patient who's more at risk.
Thank you. And I have another question also. During the last Israeli war, unfortunately, I'm talking regarding this. Luckily, you don't have problems in your country like us. The injured soldiers, after surgical interventions, they had a very high rate of sepsis. I mean, the sepsis was very high. Do you have any specific statements in ICU to treat this kind of patients? I mean, to be more aggressive from the beginning, antibiotics treatments or something like this?
No, I think the early vigilance is still what's best. So it's a lot of times it's really understanding the change in the patient. I'm not sure, I'm not as convinced, to be honest, on the prophylactic approach because that interplay of pathogen and host, we still can't predict who is going to get worse versus not. The window of intervention is key, though. So it's recognizing the change. And oftentimes, what I still find in my hospital is we're missing that window of recognition because we're seeing the change in the patient, but we're attributing it to something else. So the heart rate is rising or the blood pressure is dropping, and my residents are giving fluid, but they're not piecing it together. And our sepsis alerts are going off, and they're saying, no, it's not sepsis, but I'm coming in 8 hours later, and now they're critically ill and the window has passed and I can't intervene. And so it's that bundled approach, the timeliness is the key factor. That's what's making the difference between survival versus not.
Absolutely. Yeah, thank you.
Anybody else I have a couple of questions, but anybody else want to ask a question? Okay, so let me ask, we're talking about early identification leading to early initiation of treatment, better outcomes. And in terms of sepsis alert, what about new technologies? For instance, remote patient monitoring so that we can pick up, I don't know, a tachycardia, a tachypnea, etc., at an earlier stage, particularly if the patient's on the ward or maybe at home. And then just jumping on the AI bandwagon, what is the role of AI in terms of um, earlier detection and triggering the sepsis alert at an earlier stage? So remote patient monitoring and an AI.
Yeah. So maybe there's a lot of value in the remote patient I'll tackle the remote patient monitoring first. I think there's a lot of value, and there's a lot of institutions that are really leveraging things like virtual nursing and virtual ICU to do that remote monitoring and increase their bandwidth. Similarly, AI models, it is very dependent on the type of AI approach. So some of these machine learning models, they're as good as the data that they're working off of. And so if the data sets are not great, their outcomes are not great. When you compare the current machine learning models compared to screening tools like using SIRS, News, or Muse, their functionality is about the same. So they're not necessarily any better than our current other screening tools. So the tools are really important. The early recognition, the screening is essential. Now, as a bit of an implementation scientist, I think human behavior factors are really more of the influence on what we do with that information. And a lot of the work that I do in running my sepsis program is convincing people to act on the information. So using technology to detect early is great, but if we're not acting on the information, then it's really not making a difference. And some of I think the academic discourse around the different controversies of sepsis and the challenge with there is no gold standard test to say yes or no really play into what's happening at the bedside. And those who recognize it and say, I'm going to intervene early, outcomes are better. But there is a large population of healthcare that hesitates to go, the alert's telling me. I have a lot of people who are like, well, the alerts fire too much. It doesn't make sense. But 2 days later, the patients are in the ICU with me, and we've missed the window of treatment. And so the human behaviors of how to respond to these still very much influence the outcomes for patients.
And who represent the sort of roadblocks or the barriers in terms of human behavior? I mean, is it I don't know, physicians, non-physicians, the old guys, the new guys, who do we have to work on?
It honestly, it can vary depending on the local culture of the hospital. And so I think I have encountered hospitals where the influencers have instilled the belief in yes, sepsis bundles make a difference. And I worked in other hospitals, like I said, my hospital is hydrophobic. I think because we have a large heart failure population, and so the cardiologists have done an excellent job in instilling fear around giving fluids, and so we're not resuscitating our sepsis patients. And so local culture seems to make an influence on that. And so it's really hard. Emergency medicine, within emergency medicine, there's a lot of controversy around, especially the fluid topic. I feel like we have two camps in the American College of Emergency Physicians alone. But we've come a long way because there's been such an emphasis with SEP1 and some of the legal regulations. That's all focused on community-acquired sepsis presenting to the emergency department. So the biggest opportunity lies on the inpatient side, and really shifting that focus of early recognition for inpatient hospital-acquired sepsis as well. Because I think there's a huge gap in the approach to community-acquired sepsis versus hospital-acquired sepsis, and it's bearing out. There's huge disparate mortality outcomes there in bundle compliance as well as mortality.
Right, and it sounds like you're more in sync with the surgeons, let's say at a trauma center, right, where they're
Yeah,
They
right.
like balanced salt solutions, ringers lactate,
Yes,
and they're not afraid to give fluids because they're dealing with essentially healthy patients who have just been hit by a truck.
yes,
All right, so you're
exactly.
more on our side.
Yeah, very much.
Very good. Okay. Anybody got a final question before we wrap up? Okay. Well, it's just past the hour. It was a fantastic talk.
Thank
It was
you.
really good. I love the slides,
Thank
and
you.
thank you very much. A lot to think about, and it sounds like you know, you're really a surgeon in a critical care in critical care sort of clothing.
That's right. We're kindred spirits.
Yeah, absolutely. Thank you again.
Thank
Thank
Thanks
you.
a
you so
lot.
much. Have a
All right,
great
and thank
day.
you everybody for
Thank you.
attending.
Bye.
We'll see everybody soon. Thanks a lot.
Bye.
Bye bye.